student. Today we're going to be giving you guys a session about pulmonary circulation. So let's get right to it. Our objectives for today will be to give you an overview of pulmonary circulation, discuss pulmonary vascular resistance, the factors that might affect it, the distribution of blood flow within the zones of the lungs, and lastly, we're going to briefly discuss anatomical shunts. So, starting off simple, what is pulmonary circulation? Pulmonary circulation is the portion of the circulatory system that carries deoxygenated blood from the right side of the heart to the lungs for oxygenation, and then returns that oxygenated blood to the left side of the heart. So, to put it simply, pulmonary circulation is the journey that deoxygenated blood takes from the right side of the heart to the lungs. In the lungs, that blood will undergo oxygenation. So this is a vital step because, as all of you know, oxygen is the fuel for ourselves, to function normally. Now, with that fresh oxygen, the blood makes its way back to the left side of the heart, and then from there, it will be pumped out to the rest of the body, delivering that oxygen to the cells and tissues. So now for a very brief review of the pathway that blood goes through in the pulmonary circulation. So venous blood from the systemic circulation with low oxygen empties into the right atrium and right ventricle of the heart. Then through there, it goes through the pulmonary artery, and then from there, it goes to the capillaries around the alveoli where it picks up the oxygen. Then it empties into the pulmonary vein, and then it drains into the left atrium and ventricle. Then it gets pumped out to the body's systemic circulation. Now, please note that the pulmonary artery carries deoxygenated blood, and the pulmonary vein carries oxygenated blood. I know it's easy to mix them up as this goes against the general rule of thumb that we all know, which says that arteries carry oxygenated blood and veins carry deoxygenated blood, but the pulmonary vessels are like an exception to this rule. And for whoever is more of a visual learner, here's everything that we previously mentioned, portrayed in a simple diagram. So you can see on the left-hand side of the image, the right side of the heart is receiving deoxygenated blood from the systemic circulation through the vena cava. This deoxygenated blood is pumped by the right side of the heart through the pulmonary artery, again, not the vein, which is carrying deoxygenated blood to eventually reach the lungs where it undergoes oxygenation, then through the pulmonary vein, which is carrying oxygenated blood. This blood makes its way back to the left atrium, then the left ventricle, and eventually to the systemic circulation. So the pulmonary circulation is a low pressure system. So recall that the systemic blood pressure is about 120/80 under normal conditions. The pulmonary artery pressure, in contrast, is about 24/12. And there are several reasons it's lower, but the most important two suggested reasons it's lower is because it doesn't need to go as far. So the blood in the pulmonary artery just needs to get to the top of the lungs. On the other hand, the blood in the systemic circulation needs to go all over the body, from the head all the way down to the feet. The second most important reason for this lower pressure is that the lungs are delicate structures with delicate vessels. So higher pressure can cause damage to the thin-walled vessels. So now we will get a general picture of what pulmonary vascular resistance is. Pulmonary vascular resistance is the measure of the resistance encountered by blood as it flows through the pulmonary circulation. The resistance in the pulmonary vasculature is primarily determined by the caliber, which is the diameter of the pulmonary vessels, and the tone, which is the degree of constriction or dilation of these blood vessels. So at its core, the resistance in the pulmonary vasculature is influenced by two key factors, the caliber or the diameter of the pulmonary vessels, and the tone or the degree of constriction or dilation of these blood vessels. So in conditions where there's increased resistance in the pulmonary circulation, the right side of the heart has to work harder to pump blood into the lungs. This increased workload on the right heart can lead to right ventricular hypertrophy, which is thickening of the right ventricle wall, and if severe and prolonged, can contribute to right heart failure. Now, why does this matter? Well, when there is an increased resistance within the pulmonary circulation, the right side of the heart faces a tougher task. the heart has to work harder to pump the blood into the lungs, overcoming that increased resistance. So this increased workload on the right side of the heart can lead to a phenomenon known as right ventricular hypertrophy, where the right ventricle's wall thickens. Now, if this is heightened, the workload can persist and it can become severe, which can contribute to right heart failure. Conversely, decreased pulmonary vascular resistance allows for easier blood flow through the pulmonary vessels, reducing the workload on the right side of the heart. So, on the flip side, decreased pulmonary vascular resistance is a good thing. It means that the blood can flow more easily through the pulmonary vessels, reducing the workload on the right side of the heart. So this diagram is showcasing the phenomena that we just discussed. Pulmonary vascular resistance is determined by the diameter plus the tone of the vessels. So on the left, you can see that this vessel has a large diameter with vasodilation, so low tone. So these factors will result in decreased pulmonary vascular resistance, which indicates increased blood flow. In contrast, on the right, you can see that this vessel has a small diameter with vasoconstriction, so high tone. So these factors will result in increased pulmonary vascular resistance, which indicate a decreased blood flow. So there are several factors that can affect pulmonary vascular resistance. The most significant ones for us are lung volume, oxygen levels, cardiac output, vasoactive substances, and the autonomic nervous system. We're going to discuss each one in detail, starting off with lung volume. So there are two types of vessels within the lungs that dictate the level of pulmonary vascular resistance. You have your alveolar vessels, which supply blood to the alveoli, and resistance depends on the alveolar pressure. And then you have your extra-alveolar vessels, which supply all areas of the lungs apart from the alveoli, and this resistance depends on the pleural space pressure. So during inhalation, lung volume increases, causing alveolar vessels to collapse due to compression and decrease in diameter, leading to increased resistance. In extra-alveolar vessels, inhalation leads to reduced resistance due to vessel distension. So let's first explore the effects during inhalation. As you take a breath in, expanding your lung volume, the alveoli increase in size as well. Now, this expansion leads to the collapse of alveolar vessels due to compression, causing a decrease in their diameter. So this in turn results in increased resistance in those vessels. Now, in extra-alveolar vessels, the story is a bit different. Inhalation in this case leads to reduced resistance. Now, why is that? Because these vessels undergo distension or expansion as the lung tissue itself expands, making it easier for the blood to flow through them. So you can see on the diagram on the lower left, so with inhalation, as we said, the alveolar vessels undergo compression and they collapse. So resistance increases, hence blood flow decreases. During exhalation, the lung volume decreases, causing the extra-alveolar vessels to become narrower with a decrease in diameter. This causes increased resistance in extra-alveolar vessels. In alveolar vessels, exhalation leads to reduced resistance as a result of vessel distension. So now let's shift our focus to exhalation. As you breathe out, decreasing your lung volume, the extra-alveolar vessels respond by becoming narrower, decreasing their diameter because the lung tissue itself is shrinking. So this results in increased resistance in extra-alveolar vessels. But in contrast, in the alveolar vessels, exhalation leads to reduced resistance. So as the lung volume decreases, these vessels undergo distension, making it easier for the blood to flow through them. And you can see that on the right. So as the alveolus kind of shrinks, it pulls away from that alveolar vessel, giving it space. So then you have decreased resistance and increased blood flow. So the resistance of both alveolar and extra-alveolar vessels are in series and therefore additive. This leads to lowest total pulmonary vascular resistance at the functional residual volume and to an increased pulmonary vascular resistance, which again is decreased flow with either maximal inhalation or exhalation. So if you bring
Um,
your attention, yeah,
and then not to cut you off, but can you see the chart?
yeah. Okay,
Mm.
so Dana, when you're saying you don't get the previous point, you're referring to the slide, like with inhalation and exhalation. Okay, so basically, when we're talking about the relationship between pulmonary circulation and lung volumes, we're gonna like focus on two blood vessels, the alveolar vessels and the extraalveolar vessels. Now, the alveolar vessels are found right at the alveoli, like around it, while the extraalveolar vessels are found elsewhere in the lungs. So they kind of go in opposite directions. So during inhalation, the alveolar vessels, as you can see in the diagram on the bottom left, okay, so as the alveolus gets bigger because you're inhaling, you're pushing down on that vessel, kind of compressing it. So you're increasing resistance and you're decreasing blood flow because you're kind of squeezing it. This is your alveolar vessel. While with your extraalveolar vessel, when you inhale, your lungs grow bigger. So kind of imagine a string. You're holding a string from like both of your hands on different ends. Okay. If you put those strings together, the string is it's going to be flaccid. It's kind of going to collapse in and on itself. But if you pull it apart, it's going to become taut. So when you're breathing in, your lung tissue itself is getting bigger. So it's pulling apart those extra alveolar vessels, making them bigger. So you're having decreased resistance and increased blood flow. Do you get me? Dan, are you following me? Okay, perfect. So back to what we were saying. Um, on the diagram on the bottom, you can see how the alveolar and extraalveolar have an opposite relationship to each other, like we just said. And you can see how the total pulmonary vascular resistance is lowest in the midpoint, also known as the functional residual volume. So that kind of gray square, that's where it's the least because, as we said, it's an additive thing. So now that we discussed the effects of lung volume on pulmonary circulation, let's discuss the effect of oxygen levels on pulmonary circulation. So we're going to be discussing two phenomena, hypoxic vasoconstriction as well as global hypoxia. So starting off with the hypoxic vasoconstriction, it's important to understand the effect of blood oxygen on the pulmonary circulation. In the systemic circulation, when you have a low oxygen level, this leads to vasodilation in the systemic circulation as it interpreted as low oxygen. So basically insufficient blood flow. So vessels in the systemic circulation will vasodilate to increase that blood flow. This is basically what keeps your tissue, like your muscles, from being deprived of oxygen. While in the pulmonary circulation, the opposite happens. When you have a low oxygen level, this leads to vasoconstriction. Now, why is that the case? Well, this is a process called hypoxic vasoconstriction, and the idea is to shunt blood away from the poorly ventilated areas. Now, the lungs will interpret a low oxygen level as meaning that the portion of the lungs is not working, and they don't want to waste blood into that area. So they will vasoconstrict and shunt the blood away from that specific area that is not working well. So this will basically in turn send more blood to the more ventilated areas. So this mechanism is considered to be an advantage as it makes pulmonary circulation more efficient. So let's go for an example that will probably clear things up. Let's say that some area in the lungs is diseased or damaged, like for example, pneumonia in the left lower lobe. So the partial pressure of oxygen in those alveoli will be low, and that would decrease oxygen delivery to the blood flowing into that region of the lung. So what happens is that in response to the low levels of oxygen in the alveoli of the left lower lobe of the lung, the smooth muscle that's wrapped around the arterioles of the alveoli starts to vasoconstrict. So this basically shuttles the blood away from those damaged areas of the lungs and towards the healthy lung tissue, where the partial pressure of oxygen is higher and the blood can be oxygenated more efficiently. So now for the mechanism of why this actually happens, you have two pathways, starting off with the one on the left. Hypoxia is believed to inhibit a potassium channel in the membrane of smooth muscle cells of pulmonary vessels. And this inhibition of potassium channels depolarizes the cell membrane and opens the voltage-gated calcium channels through which calcium enters the cell and causes contraction, which will in turn cause vasoconstriction. In the second mechanism, you can see on the right, where hypoxia leads to release of endothelin 1 from the endothelial cells, causing contraction of smooth muscles, again, vasoconstriction. So now that we've discussed hypoxic vasoconstriction, let's discuss the second phenomena that plays a role in the effect of oxygen levels on circulation, which is global hypoxia. So, global hypoxia refers to a condition where there is a generalized or widespread decrease in oxygen levels throughout the entire pulmonary vascular system, as opposed to our previous topic where it wasn't widespread, it was in just one specific area of the lungs. So, global hypoxia is considered to be a disadvantage in contrast to hypoxic vasoconstriction, which is considered an advantage, and it's an efficiency and protective factor. So, global hypoxia and pulmonary circulation can occur for various reasons, such as a ventilation perfusion mismatch. If there's an imbalance between the amount of air reaching the alveoli and the blood flow through the pulmonary capillaries, it can lead to inadequate oxygenation of the blood. The second reason would be a reduced inspired oxygen. So if the concentration of oxygen in the air itself is low, for example, this is what you get in high altitudes, it can contribute to global hypoxia, as the entirety of the lung tissue itself isn't receiving oxygen. And then lastly, we have certain lung diseases. So conditions such as chronic obstructive pulmonary disease or pulmonary fibrosis can impair the normal exchange of oxygen and contribute to global hypoxia. Now, complications due to this excessive widespread vasoconstriction include pulmonary hypertension and pulmonary edema, with high altitude pulmonary edema being a specific complication of reduced oxygen inspiration in high altitudes. So now for the effect of cardiac output on pulmonary circulation. Cardiac output decreases pulmonary vascular resistance in multiple ways. Um, so first off, you have recruitment, which is opening of closed reservoir vessels. And then you have increased vessel distension, which is further dilation of previously perfused vessels. So in more simple terms, you're creating new pathways, which is your recruitment. On top of that, you're making your existing pathways more efficient, which is your increased vessel distension. So exercise causes cardiac output and thus increased cardiac output, sorry. And thus the lung perfusion increases by 3 to 6 fold of their levels at rest. The pressure in the pulmonary artery, however, increases much less, maximally by factor of 2. Since the driving pressure difference increases much less than the perfusion, the pulmonary vascular resistance has to be reduced. Passive and active forces are involved in determination of the PVR. So, to begin with, when we exercise, our body undergoes physiological changes. One key aspect is the increase in cardiac output, which basically refers to like the volume of blood that the heart pumps out per minute. Now, this surge and increase in the cardiac output while we're exercising will influence the lung perfusion, uh, which is basically, again, as we said, it's the blood flow through the lungs. So, similar to cardiac output, the lung perfusion will also increase significantly by 3 to 6 fold during exercise, supporting that increased demand of oxygen in the body's tissue as you're exercising. So, while cardiac output and lung perfusion experience like really high increases, as we said, 3 to 6 fold. The pressure in the pulmonary artery itself doesn't rise as dramatically. It usually maximally increases by a factor of 2. Now, why is that? As we said, they're thin vessels, so they can kind of يعني, hold up to that increased blood volume without increasing that much in pressure. So now for the effect of vasoactive substances on pulmonary circulation. Pulmonary vascular resistance can be affected by various vasoactive substances by affecting the tone, so dilation or constriction of the pulmonary blood vessels. So listed on the right are substances that decrease pulmonary vascular resistance, hence they increase blood flow. Starting off with histamine. Histamine is a vasodilator, meaning it promotes the relaxation and the widening of these blood vessels. In pulmonary circulation, histamine, sorry, as we said, leads to vasodilation, reducing the resistance and increasing the blood flow. Then we have nitric oxide. Now, nitric oxide is a powerful vasodilator and is particularly important in regulating blood vessel tone. So again, as we said, in pulmonary circulation, nitric oxide causes vasodilation, reducing pulmonary vascular resistance and improving the blood flow. So just like histamine. Lastly, we have prostaglandins. Now, prostaglandins have many diverse effects, but some of them can act as vasodilators. Then on the right-hand side, you can see the substances that increase pulmonary vascular resistance, hence they decrease the blood flow. So starting off with serotonin, serotonin has vasoconstrictive properties, meaning it induces the constriction of blood vessels. So in the pulmonary circulation, serotonin can cause vasoconstriction, increasing pulmonary vascular resistance and reducing the blood flow. Lastly, we have angiotensin 2. So angiotensin 2 is a potent vasoconstrictor, and it plays a very big role in regulating blood pressure. So in the pulmonary circulation, angiotensin 2 can induce vasoconstriction, leading again to increased pulmonary vascular resistance. Now, please note that all of these substances have little to no clinical significance apart from nitric oxide, which has clinically been used to reduce the pulmonary vascular resistance. So while sympathetic and parasympathetic nerves exist in the lungs, the autonomic nervous system has negligible influences on pulmonary circulation and pulmonary vascular resistance. So nonetheless, pulmonary vascular resistance can be modified by autonomic nervous system modifying drugs. For instance, beta-2 agonists employed in asthma treatment induce bronchodilation, affecting pulmonary vascular dynamics. So the most important thing to remember is that the autonomic nervous system has little to no effect on the pulmonary circulation. And that's basically it. Now, for the distribution of blood flow in the lungs, blood flow within the lungs isn't uniform. Rather, it's divided into like zones ranging from heavy blood flow to minimal blood flow. So the zones of the lungs are determined by the relationship between the alveolar pressure, arteriolar pressure, and the venule pressure. So at the apex of the lungs, arteriolar pressure and venule pressure are relatively low, while at the base of the lungs, arteriolar pressure and venule pressure are relatively high, while in the middle, they're somewhere in between. Now, why is that? Because when you're standing upright, gravity causes more of your blood to kind of go to the lower part of the lungs, so this increases the pressure in them. So the lower you go, the higher pressure you're going to have in these arterioles and venules. So because the alveolar pressure is constant, the relationship of the arteriolar pressure and the venule pressure with kind of a relation to that alveolar pressure changes. So alveolar pressure is always going to be the same, but the arteriolar pressure and the venule pressure are what changes. So kind of the relationship amongst those three is what determines the zones of the lungs. So when I explain it, it's probably going to be a bit clear. We're going to start off with zone 3 all the way at the bottom. So in zone 3, at the base of the lungs, arteriolar pressure is higher than venule pressure, and both of them are higher than your alveolar pressure. So P capital A is your alveolar pressure, P small a is your arteriolar pressure, PV is your venial pressure. So the blood flow within zone 3 is the highest, as you can see by the diagram on the right. So again, because the pressure amongst the arterioles and venules is higher than that in the alveoli, the vessels aren't going to collapse or anything under their pressure. They're just going to stay wide open and blood's going to flow through them freely. In zone 2, right above that, the arteriolar pressure is higher than the alveolar pressure, but alveolar pressure is higher than the venial pressure. So this kind of changes from zone 3. So zone 3, from highest pressure to lowest pressure, it was your arteriolar pressure, your venial pressure, and then your alveolar pressure. In zone 2, your arteriolar pressure remains the highest, but basically your alveolar pressure and venial pressure switch. So in zone 2, your alveolar pressure is going to be higher than your venial pressure. Um, so as we said, again, arteriolar pressure is higher than alveolar pressure, but alveolar pressure is higher than venial pressure. So this causes the venules to get kind of slightly crushed, decreasing their diameter and increasing in their resistance, which leads to a decrease in blood flow through them. But arteriolar blood continues to flow into the venule, overcoming that alveolar pressure as the arteriolar pressure is still higher than the alveolar pressure. So it's able to push through. So again, you can see on the diagram, the arteriolar side, so the left side marked PA, is wide open. It's not having any issues because that pressure is higher than the alveolar pressure. But then when you go a bit to the right side of the image, that's where your venial pressure comes into play. As it's lower, it will slightly get crushed, but the blood coming in from the arteriolar side again has a really high pressure, so it's going to kind of help it open up a tiny bit. So it's not going to be fully open, but it's just going to be opened a tiny bit. In zone 1, at the like extreme apex of the lungs, alveolar pressure is higher than arteriolar and venial pressure. So in this zone, blood does not flow because the arterioles get crushed by the really high pressures in the nearby alveoli. So you can see in the diagram, both the arteriolar side and the venial side are completely collapsed due to the really high pressure within the alveoli in relationship to these vessels. So here you can see everything that we just mentioned on a more gross level. So blood flow in zone 3 is the highest, and in zone 1 is the lowest. And that's basically kind of what you need to pick up from this diagram. Now for our last objective, we're going to be discussing normal anatomical shunts. Now, normally about 2% of the blood follows like a slightly different pathway from what we're used to. It's diverted or shunted so that it bypasses the pulmonary capillaries, and this is called a physiological shunt. Now, there are two main ways this happens. First, when the blood goes out to the heart muscle itself, so through the coronary arteries, it returns through these tiny veins called Thebatian veins. So rather than draining into the venous system and going into the right atrium, these Thebatian veins sometimes dump that blood into the closest chamber of the heart, which could very easily be on the left side of the heart. So, for example, if the blood that goes through the coronary arteries to the
Adnan, hi. I don't know if you're still talking, but we can't hear you.
the pulmonary circulation.
Okay, great. You're back.
Uh, you guys couldn't hear me?
Yeah, for like a good like second there, like you cut out for a second.
Oh, top. I hope you guys like didn't miss anything important. If anything is like not clear, you guys just tell me and I'll repeat it.
Come on.
So, second, the airways of the lungs, like the bronchi, receive systemic arterial blood from the bronchial arteries, but the deoxygenated blood can flow right into nearby pulmonary veins, which are carrying oxygenated blood that has already traveled through the pulmonary capillaries. So, as we said, pulmonary veins carry oxygenated blood. So, once again, that deoxygenated blood might flow right into the pulmonary veins and mix in with the rest of the oxygenated blood, bypassing the pulmonary circulation. And yeah, that's basically it. Now for a couple of quick questions. So, during maximal inhalation, which statement is most accurate? A, alveolar vessels have decreased PVR. Extra-alveolar vessels have increased PVR. B, alveolar vessels have increased PVR. Extra-alveolar vessels have decreased PVR. C, alveolar vessels have increased PVR. Extra-alveolars also have increased PVR. D, both of them would be decreased. E, alveolar would be increased while extra-alveolar would remain the same. So if Dana is still here, considering I explained this specific thing to you, would you be able to answer this? We'll give you a second. If you can't answer Adi, just say it in the chat and I'll answer it. And I'll explain it. Okay. So the answer here would be B. So as we said, when you're inhaling, your alveoli are expanding. Your alveolar vessels are right under that alveol, like those alveoli. So imagine you have a box with a balloon and a tube inside of it. Okay. When that balloon is expanding, it's kind of pushing onto that tube, collapsing it. So when you're collapsing it, you're increasing your resistance. PVR is your resistance. So when you inhale, that alveolus becomes bigger and it pushes up onto that vessel, kind of collapsing it and increasing the resistance with it. While on the other hand, your extra-alveolar vessels have decreased PVR. That is because as you're breathing in, your lung tissue itself is becoming bigger. So these extra-alveolar vessels kind of stretch wide open, so their diameter becomes a lot bigger. So that decreases your resistance and increases the blood flow because they're becoming bigger. You're kind of pulling them apart. That's basically it. For the second question, which of the following mechanisms correlates with the effect of decreased oxygen levels on pulmonary circulation? A would be release of endothelin 1, B would be release of endothelin 3, C would be inhibition of potassium channels, D would be inhibition of calcium channels, E would be A and D, F would be A and C, G would be C and D. Now, this I'm going to answer myself, would be, I'm going to give you guys a second to say it in the chat. Okay, it's F. So it's both A and C. So release of endothelin 1 and inhibition of potassium channels. I'll go back to the slide itself to show you guys. You can see over here. So hypoxia would cause an inhibition of pulmonary vessel, smooth muscle cell, potassium channels on the left. On the right, you can see hypoxia also causes the release of endothelin 1. And both of these things would cause vasoconstriction. And yeah, that's basically it. So if you guys have any questions, you can go ahead and type them in the chat or just unmute yourself and ask. Okay, I guess no one has any questions. So thank you for listening. I hope the session was beneficial. I'll type my phone number in the chat. If you guys have any questions, whether it be to this specific lecture or any other lectures, you can just text me on WhatsApp or call me, and I'm more than willing to help. And there's this QR code. If you guys can please scan it, it's a survey. It's just one question. It's not going to take you more than 10 seconds. So please, if you guys have the time, just go ahead, scan that and answer the survey. And yeah, thank you. Have a good day.